Hello, and welcome to the webinar, The Dental Needle, Improving Patient Satisfaction and Practice Growth. My name is Sean Boynes. I am the Director of Interprofessional Practice at the DentaQuest Institute. Prior to taking this position, I was Director of Dental Medicine at CARE South Carolina, and prior to that, Director of Anesthesia Research at the University of Pittsburgh. With today's model, what I'm really hoping to disseminate is information about the dental needle itself. The mechanics and the engineering that goes into a dental needle and how that can be effectively used in practice, and hopefully also making you more informed as a consumer over to what type of products are going to be advantageous. So just like you want to look at a car that you're going to buy at all the ins and outs and all the reports, my hope is to provide that same level of information with dental needle. And so really when we talk about the dental needle, it's in dentistry it's most commonly used for administration of local anesthetics. And when we think about how people react to dentistry, the dental needle is one of those things that you tend to associate with a dental visit, unfortunately, because it carries a negative connotation, which can present itself as pain, anxiety, and dissatisfaction. Now, in dental lore, the needle plays one of the most important roles, as it is often thought of as that torturous device used in those dental offices. It does tend to be the first thing that a patient thinks about when considering any dental care, and there's several reports in literature that tell us that the majority of patients actually think every dental appointment may have a needle involved, even if they know they're going just for a routine cleaning. So ultimately, it's very influential in a person's perception of the dental profession. Now, we do have 10% of the world's population is characterized as needle phobic, and it is a formal medical condition. If you look at the DSM-5, the way that they determine if somebody is having just anxiety or a bad day, as opposed to actually being phobic, is whether or not they avoid care. So if there's an actual physical desire to avoid care at any cost, that is considered a phobia, and 10% of the world's population have that with needles. Now, when we look at some of the research, it tells us exactly where this comes from. It looks like it's both genetic and learned. A great report that was done by Dr. Chet Sokolowski in dental clinics in North America in 2010 demonstrated some of these genetic linkages and showed a great study where twins that had not been together throughout their life would have similarities in avoidance characteristics with needles. And there's also some information that a lot of this can be learned. It can be learned along the facts of just being afraid of sharp objects and to stay away from those, to the fact that some parents may use negative experiences in healthcare as a means to assist in parenting, such as clean up your room or I'm going to send you to the dentist to get a shot. And so those things all factor into what gets eventually put out as a phobia and anxiety of dentistry. Ultimately, it's related to most of the dissatisfaction reports that we see. D. St. George's in Dentistry Today in 2004 kind of looked at the most popular ways that dentists are judged, and the number one way, and it's fairly consistent, is whether or not a dentist or a dental provider can provide a quality injection. And so comfortable injections are considered a practice builder. If you're no good at it, it's considered a practice destroyer. And when we look at reports of bad dental experience, the majority of those relate in some way, shape, or form to pain or perceived pain during dental care. And so as we delve in more into the world of needles, it's always important to know what the market looks like. The most recent reports that we have available are 2006. It's hard to get really up-to-date information on the market that is publishable, and so we tend to lag behind. But in 2006, about 2% were using 25 gauge, 27 gauge needles were getting about 40% of the market, and close to 57% of the market was 30 gauge needles. My understanding in talking to people in the industry is that that 30 gauge needle mark has actually increased, and we've gone closer to 60-61% with seeing a reduction in 27 gauge needle usage. So that's kind of where the market is bearing at this time. Now, over the last 30 years, we have seen this shift towards the use of smaller diameter needles. We've really shifted from 25 gauge to 30 gauge needles. A lot of this is based on the assumptions that there would be less trauma and discomfort with a smaller needle. However, when we start looking at research, especially research that was conducted intraorally, that these needles and evaluation of pain may not necessarily correspond to the actual gauge of the needle. And we'll talk a little bit about that in the next few slides. But first, it's important to understand pain perception, because ultimately that is what we're trying to do, and that is what the engineers that make the needles are trying to do. The engineers are trying to develop a structure that's going to decrease the amount of pain that the patient undergoes, and we're trying to understand those characteristics to be able to use that engineering to the most efficient manner. And so we need to know pain perception. At the end of the day, it's really a survival mechanism. And so the way that our brain is wired is that if there's some untoward or bad stimuli or stimulus that may cause tissue damage, we detect it in our terminal nerve endings. It goes through pain detecting fibers into the brain and says, man, that hurts, you might want to stay away from that. And so ultimately that pain perception is brought on by our body's desire to thrive and survive. And so it's a way to think about it when that patient's in the chair and they do have this perception of pain coming. It's one of those things that we have to help them get through in order to overcome some of the perception that's there. And so we are wired to avoid pain. We really do not want to be stabbed much by anything. So we have two main fiber groups. We have type A and type C. I know there is a litany of nerve fibers for this particular presentation. Since we're talking about needles, I'm just generally talking about the nerve fibers as a way to think through the engineering of the needle. And so the type A nerve fibers, these are our fast conducting fibers. They're most likely to respond to mechanical stimulation associated with that sharp and vivid pain perception, and they're also closely associated with the free nerve endings. So if you think about your nerve tree where you have your nerve trunk and then you have your all the way down to your terminal endings, there was always these free nerve endings that sit in the mucosa, and we use topical anesthetic to affect them the majority of the time. But if you break them down to the microscopic level, they tend to be closely associated with type A nerve fibers as opposed to the C. And so the type C nerve fibers, these are your slow conducting fibers. They respond more to thermal and chemical sensation. This is more of an aching or burning sensation that's perceived by the patient. And so when we think about how pain perception works with the chronology of the dental injection, so the first thing that we do is the needle penetrates the mucosa. These are going to be your type A fibers, which are going to get the initial sharp type of pain stimulation. Most providers use topical anesthetic to obtain the pain level, and one thing to think about is that the bevel of the needle can be just as important in decreasing that type A pain reaction with mucosa penetration. And so the needle can play a role as we go through each step of the injection process. When we look at the next pain response that the patient can have, it's usually the deposition of the anesthetic solution. Ultimately, this does tend to be considered the most painful portion of this process. Most patients will rate this higher than the actual needle penetration in the mucosa. This is usually described as a burning or aching pain, and it involves both the type A, with the expanding of the tissue and impulse waves from the deposition of the anesthetic, and the type C pains due to the chemical complexion and the pH of the local anesthetic. And so some of the things that we do already is control the speed of deposition. We want steady hand movement, and some providers are actually buffering the anesthetic to make the pH more basic, which would decrease pain on deposition. As it relates to the needle, we can think about the bore design that can play a role in helping us with this portion of the pain aspect, which would allow us to decrease some of the solution. And then if we look at the next step, pain perception and the dental injection, that's the needle withdrawal, which is something we tend not to think about, but this also involves both the type A and type C fibers, and usually ends up directly relating to postoperative pain. There's association with the pH of the anesthetic, and with the administration of multiple injections or poor technique is usually on this area where that postoperative pain comes in. There can also be some issues with the needle itself, with barbing, peeling, or splintering, and the structural integrity plays a vital role. And so when we start breaking down what needle, the design of the needle that plays vital roles into each one of these areas of pain perception, it looks like this, which with penetration we want to know about the bevel, we want to know about the structural design and what type of coating is on that needle. With deposition, we're interested in the bore and the lumen, and on withdrawal we want to know more information about the bevel design, what structural design and steel integrity is present, and also the coating. And so what we want to do now is kind of talk about these needle properties, look at the research that's around each of these properties to help with a better selection of a quality needle that will improve the patient experience. And so there's huge variation in how a needle is selected. Needle types that we were familiar with during training, we're more likely to continue to buy those. There's peer influence. Dr. Smith down the street told me about this, said they're really good. You try them, you like them. Probably the most important factor that we see from needle selection is economics. It's how much does it cost and how affordable can I get it. A lot of needle influence also plays out of deals. Buy 4 boxes, get 1 free. More likely to select that needle design than one that is not. And there's also the thought that the needle is a needle. And hopefully after this particular webinar, you'll have the idea of the differences in manufacturing and design that can occur that may result in an unsatisfactory dental visit. So the first thing we want to talk about is needle gauge. Needle gauge is the diameter of the needle. Here in the United States, they come as 25, 27, and 30 gauge needles. The higher the gauge, the smaller the diameter. And what we've seen over the last 30 to 40 years is a shift to smaller diameter needles from 25, 27 to where the majority of the market is using a 30 gauge needle in the United States. And that's based on conjecture that smaller needles equal smaller pain perception. And that's really not the case when we look at research. And I've named some of the more cited studies down here at the bottom of the page, but you can go back to 1964 and pretty much for 2 publications each decade up until today, we've seen studies that show that a 25 gauge can be used just as painlessly as a 30 gauge, to patients not being able to differentiate any pain threshold between the different needles that were used, to inpatient analysis that finds that there's no difference in not only gauge but also injection type. And so at the end of the day, the research is telling us that it really doesn't seem like the gauge is that much of a factor. Now, a lot of these ideas came out of preconceived notions from medical literature, which were looking at inoculations in children. And so when they were looking at inoculations with the thigh, the buttocks, and the deltoid being the most common places for administration, they did find that smaller gauge needles were more beneficial in those particular instances. However, in dentistry, intraorally, we've not found that. And the theory that's put forth is that it's because there's more sensory neurons located intraorally than there are within the deltoid, the buttocks, or the thigh. And therefore, the patient's response or the subject's response in this study tend to be that they all hurt. It wasn't that one hurt less, it was that they all hurt. And so that does lead that theory to being there's just too many sensory neurons for patients to detect a difference in pain threshold for the majority of practitioners providing injections. So we do have a bevel, which seems to be more important overall than the gauge. And there's 5 different bevel types that you can get in the U.S. There's the long, the medium, and the short bevel, which are the oldest standards that we have. The multi-bevel, as you can see, has kind of a dip in the side that allows for a better cutting surface and also a lifting away of the tissue away from the shaft that allows for less coefficient of friction as it penetrates the mucosa. And then the newest bevel type that we do have is the scalpel bevel, which has pretty much what it says is a scalpel design to the top, and we'll talk a little bit more about that type of bevel in the next couple of slides. So at the end of the day, when we talk about gauge of the needle versus the bevel, it does seem that research tells us the role of the bevel is to cut surface, to decrease the resistance as the needle penetrates and withdraws from the tissue. And so there are several researchers that advocate that sharpness is more important than the overall gauge or size of the needle. And so what we look at through this research is that you really want a sharper needle, not a smaller needle. One that's sharper, not necessarily smaller. So if you have a better bevel, you have a decreased force. This is a study that was done by Steele, looking at the overall force that needed to be applied in order to penetrate the tissue, and they found that with this particular bevel design, which was the scalpel bevel design, that 29% less force was required to go through the tissue. Now, honestly, how much patients feel as that goes through, they'll be able to feel the force, but one of the areas that we don't think about when there's more force is post-operative pain and soreness, which if you're causing pressure or you're causing a neural reaction over a wider area because of the force, patients are going to tend to have more post-operative discomfort. And so trying to think about a clean cutting surface as you go through the tissue should help decrease the amount of tissue actually being involved in the overall process. And so theoretically you would assume that that patient would have less tissue damage and thus less post-operative pain when done. So at the end of the day, as resistance to tissue decreases, patient comfort has been important to improve, and that's what we've been talking about with having a better cutting surface. The designs with the lowest tissue resistance are the ones we pointed out earlier, the multi-bevel point design and the scalpel bevel design. To quickly talk about the scalpel design, which is known as an evolution needle, this is put out by Septodont. The design has shown that you need less force than a standard version to penetrate through the membrane. Now, as you can look at this, I hope that you're saying, there's no way I'm going to use that for any nerve block, because you really should not use this for any nerve block. It does have a better cutting surface. It does, at least in my clinic, has helped with decreasing pain on penetration of the mucosa, especially for kids. But I tend to use it on kids with anterior restorations or anterior care that is needed. So it seems to allow for a much better cutting surface. I have not encountered any more bleeding with that particular needle as opposed to any others, and it does seem that the kids respond better to that, especially on those anterior teeth where it's really hard on kids to try to let them understand that process. So the more comfortable that you can make it, or the more comfortable I made it, the happier I was in clinic. And so I really think this unique design has a very good role in dentistry, especially when using your toolbox the right way. And so that's where I see this design at. I cannot stress enough to not use this for inferior alveolar nerve block injections or anything along those lines. But it does have a role. The other thing about the bevel, so we talked about the bevel as being important for a cutting surface, and that it's really the bevel design and the structure of that that's going to make things comfortable for your patient, not necessarily the size of that needle. One of the other myths that is out there is that the bevel should always be oriented towards the area to be anesthetized. I remember when I was learning local anesthesia injections, the same thing was told to me, but there's a study, this is probably the most well known, this was done by Stein-Kruger. It was published in Journal of the American Dental Association in 2006. And basically what he found was it didn't matter where you put your bevel. It really didn't matter as long as you were within the general, the appropriate area, not the general area, but the appropriate area in order to do the injection. And so the idea was, previous to this, is that you always wanted to bevel towards the area that you were anesthetizing in case there was a deflection. It increased the odds of it deflecting the right way. And what we found is that really it should be based on bevel displacement or deflection overall. And so if you have a needle that is designed with the axis tip asymmetrically off, in other words, it's not allowing for a nice diffusion of force as seen there, then what happens is the force actually goes down on the bevel and causes the needle to displace. But they actually design needles that do not deflect. What happens is, if you look at the top picture here, instead of the bevel being oriented to where the tip of that needle is going to allow the force to not go down the center of the shaft, what that does is not allow for the needle to deflect as greatly as needles that aren't designed that way. And so what you really want to find is a non-deflecting needle. And they actually make those and say they're non-deflecting. And so that's one of the characteristics you would like to see. Because then you don't have to worry about this displacement away from the area that you're trying to anesthetize. It does ultimately depend on engineering, and so you want to make sure that it's centralized. If it's centralized, if you think about the tissue and how the bevel goes in, it should be like a wedge or an X, cleanly splitting wood. The tissue should separate around the area, allowing for the needle shaft to be penetrated into the area where you need to deposit. The cleaner that cut is, the less tear there is, which means the primary healing can occur, which decreases post-operative pain management. Whenever it's rough and jagged or it's tearing through the tissue, you're going to have more damage, you're going to prolong the healing process, and probably not have the ideal primary healing that you want. So the next characteristic that can play a role is the bore and lumen. Now, what the bore lumen is the hollow portion of the tube. And so this is where the solution actually goes into and comes out of. And it's designed in a way that's supposed to allow for a predicted flow of anesthetic out through the needle end. So it can correlate with patient comfort due to something called injection pressure, which can be a variable with provider technique, and we'll talk about that in a second. So here's a picture of what it kind of is thought to look like. As you can see, while it doesn't seem like we have a lot of fluid coming in a microscopic level, it's a lot of force. And so what you see in the green-yellow is actually sensory neurons interorally. Obviously the reds and the blues represent capillaries, the arteries and veins, for lack of a better description. But the other portion is the water, which is going in and causing a great amount of force and affecting several sensory neurons, which will obviously cause a pain response. And so, you know, it can actually be pretty substantial. So Kudo and Pashley both did studies looking at the overall injection pressure for intraoral administration. And they found that the pressure was generated was like 325 to 675 psi. And I have two pictures there on the right hand side of the screen showing you, just for relation, 200 to 250 psi is like your standard garden hose with your general rate nozzle. And up towards the high of 650 to 1500 is a left-handed jab from a boxer. And so these are substantial amounts of pressure that can be created intraorally. You know, it is variable depending on the operator, but obviously can lead to discomfort. And so a lot of the theoretical aspects that have some evidence-based structure to it is that the the type of design of your needle can really affect the injection pressure, because at the end of the day, it's when you depress the plunger, it creates a flow of solution into the tissue. And so what you're trying to do is actually overcome the force that is being pushed back from the tissue to allow the solution to be forced into this area. And where that injection pressure gets created is actually where that harpoon is engaging that rubber stopper to push that fluid through. And so the idea behind a larger lumen is that it should give you more control so that you feel less resistance to allow for a smoother flow. What it appears it does not do is give you a be-all and end-all. And so here's a new study. This came out a couple months ago. It was in the Anesthesia Progress. They found no difference in larger standard bore needles and pain perception. Now, it was only on 20 patients, but I think what this particular study has done is allow an opportunity for discussion around the use of bore size in practice. And so here's some of the comments on the study. They only used one time interval. So 15 seconds across the board, 5 seconds for a long buccal, 15 seconds for an IA. And they came up, one of their conclusions that they felt needed further research was other time intervals or rates of injection may show significant effect on perception of pain. And so Dr. John Meakin, who is from Scotland and a wonderful lecturer on local anesthesia, has long said about larger bore size that the variable attached with how a provider actually deposits the solution makes a bigger portion of how much pain is perceived by the patient than not. And that's really what this study is saying. The idea behind the larger bore size isn't necessarily to allow you to be able to push that as fast as you want or at the same selection. The idea is that that particular needle in certain providers' hands will allow for a better control and a smoother deposition of solution. And so it'll work as a mechanical ability or mechanical tool to allow you to get more control, because that way you should not have to press as hard on the harpoon to allow the fluid to progress into the tissue. And so by decreasing the amount of force you have to provide, it should give you more control, especially with the initial push into the tissue. That initial push into the tissue is where patients seem to have the largest reports of pain. And so the idea behind this would be, in some clinicians' hands, it depends on, some clinicians use different burrs, some clinicians use different things along those lines to that work better in their practice with their patient population. You may find the same thing with this. But where I seem to see it having the most impact is really as a tool in your toolbox that's going to allow you better control of the first deposition of solution, because it should decrease the overall force that you have to push initially on the rubber stopper to get the solution out and to allow enough space to open in the tissue that the fluid can start being deposited and diffused. One of the other characteristics is needle coating. It actually dates back to the 1960s. It was started really from surgery. In these particular studies, what they were finding was that unless the needle was coated, they were going through a lot of needles to suture up individuals. And so they found that silicone was the best way to maintain the integrity of the needle. And so since that time, we've pretty much had all needles that had some sort of coating. Now, the most popular today is silicone, and it really happens one of two ways. There's either a spray and a respray, and then it's packaged to go out, or there is a spray-bake spray and then packaged to go out. It does appear that the spray-bake spray technique does have better reported outcomes. Now, it's not been used in a live trial yet, so we'll still need to go and evaluate that. So there are complications and adverse events that can occur. One of the dreaded ones is the needle breakage. Here's a picture that you can see with the needle that's been lodged into where the infraalveolar area is at, the pterygomandibular space. Good news, since the introduction of the non-reusable stainless steel, we've seen needle breakage become extremely rare. Pagrel, who did an evaluation in Northern California, found it to be about 1 in 14 chance of actually occurring. When breakage does occur, it usually relates to operator error or misinformation in the use of needle size. But at the end of the day, very important to take home message is it's very rare. It's something to talk about when we talk about needles, so just in case it happens, you're prepared for it. But please understand that this is a very rare event, but it can happen. When we look at all the reports, this was done by Dr. Stanley Malamed in Dental Clinics North America in 2010. What he did was he looked at a summary of all the reports of broken needles, broke it down by the reports, and basically at the end of the day found that they were more common with nerve blocks, specifically the infraalveolar nerve block and the posterior superior alveolar nerve block, and pretty much, you know, stuck within those two parameters of injection technique. The other thing that was found was that the 30 gauge needle tends to have the highest incidence of needle breakage versus a 27 gauge, and of course you'll notice that 25 gauge needles are not on this list at all. It's because they had no reports associated with them. So when we talk about needle breakage, there is a prevention technique. Here's the reports. These are some of the recommendations that are out there. Avoid using smaller gauge needles like 30 gauge or higher. You'll see this report either simply as how this is read, just avoid using smaller gauge needles, or you may see it reported as avoid using smaller gauge needles for mandibular nerve block injections. Both can be true. A lot of this is born out of the fact that when we did look at the incidence reports, 30 gauge needles were more likely to break than other needles, 25 or 27. Eliminate the practice of administering standard IA and B with a short needle. Believe it or not, we do tend to do that more in the United States than other developed countries. You know, the technique is really with a long needle. If you're using a short needle, you're probably using a different technique as opposed to an infraalveolar nerve block standard technique, but it is done with some frequency in the United States. You should never advance the needle past the point where the hub is flush with the mucosal surface. Avoid bending the needle. I know that people bend the needle, but whenever we're talking about it, the recommendation is to avoid it. The one thing to always keep in mind is that the minute you bend the needle, you lose any backing from the manufacturer on the quality of that needle. And so that is something to think about, because the minute you bend the needle, you no longer have manufacturer backing in what you're doing. Do not produce excessive lateral force during injection. A lot of these breakages, when you break them down, were associated with the walk-back technique as a primary technique that was being administered. So you would go in short and walk the needle back until you fell into the end of the pterygomandibular space where you would inject. Exercise caution and vigilance when administering local anesthetic to children, special needs patients, and dental phobic patients. There were a few dental phobic patients related to these reports. Those tend to be the toughest. I think as a profession, when a child or a special needs patient sits in a chair, we tend to be fairly vigilant, and we're aware that, you know, they might get up unexpectedly. The dental phobic patients tend to be harder because somebody could be hiding that really well and be holding that all inside, and so the ability for us to be able to decipher that, it plays an important role in prevention. If you've done everything that you needed to do, but yet it seems that this happened to you, you have two options that can occur immediately. One is whether the needle becomes embedded or if it's still visible. If the needle is still visible, then as soon as you can, get a hemostat, get a cotton plier, whatever it can be, and grab the needle and slowly pull it out. It moves very fast to be, for lack of a better term, really ingested into the tissue. It's just the way that the pressure mechanics are, where that tissue is going to try to pull that needle into itself, and so because of that, trying to get it timely and calmly is very important. If you did not, and the needle becomes completely embedded, here's the things that you need to do. You want to take radiographs of the area from both lateral and frontal planes, as well as a pan if available. If you have the cone beam technology, that's going to be very beneficial, so go ahead and take that as well. Save the hub for structural evaluation. What you want to do is you get an empty sharps container, you put the entire syringe with the cartridge, including the broken off tip of the needle, into your sharps container. That way, whenever it's surgically removed, the surgeon will be able to grab that with the remnants that are pulled out of the tissue and compare to make sure that they've gotten all of the needle parts that may be in the tissue. Record the exact sequence of events and patient's record. Refer to the patient for further evaluation, ENT, plastic surgeon, OMFS. I always tell everybody if this does happen, get them to wherever you can find them to get the quickest. If it's an oral surgeon that you refer to and you can get them in, that's usually the best because they're within the dental discipline, so they would have a little bit more knowledge around being able to treat. But if you cannot, then whoever you can find them to get to the quickest is going to be better. And of course, there's always possible involvement of malpractice carrier with this one. The reason is because the surgery, unfortunately, to remove the needle piece has to be done extraorally. They can't go intraorally. And so it does cause, it can, depending on the provider, cause facial scarring. And so we do want to try to avoid this at all costs. The next thing I want to talk about is needle barbing. And I do have some questions coming in. I'm going to save them for the end, but I promise I will give enough time to answer them all, hopefully. Needle barbing is something that occurs, it's really hard to see initially, although the picture that you see on the right-hand side is just done with a standard lens, and you can see the barbing on the end of those long needles. At the top is probably more characteristic microscopically of what we would see, which is really just to turn into that very tip of that needle. Now, it's basically anytime the tip becomes bent in or out, it usually occurs at microscopic levels. It can even happen during syringe preparation. A lot of people will bang the top of the needle down on the countertop, and that can cause damage to the top of the needle. It can also happen with just going through tissue, more common with multiple injections or when contacting bone. And they can be dangerous. They can tear tissues, and that includes nerve fibers, which there are some reports in literature of lingual nerves being severed by barbed needles. And so they can become an issue within practice. It happens most often with infraalveolar nerve block injections. Reported barbing incidence is between 30 and as high as 78%. Obviously, we see more barbing when bone is contacted. So when we talk about needle design, a needle that has manufacturing defects is going to obviously be more prone to barbing and also to splintering. These irregularities usually happen during the cutting process and are more likely to happen if the quality of steel being used in the needle is not to the standards that are required. And so you have the International Organization for Standardization, and it is a worldwide organization that provides the type of stainless steel as well as the minimum thickness of steel to be used in needle manufacturing. So the question is do people follow these standards? Well, what we found in a recent study that was done out of the Middle East was there was no correlation or consistency with metal alloys to international manufacturing guidelines for the majority of needles that were on the market. They did say there was a wide variation between the applied standards, and that most manufacturers just applied their own standards to the manufacturing process. So you can imagine if you're thinking about cutting a needle, it's very precise. You need things that are very sharp and equipment that allows for the type of cuts that are within microscopic levels. And so if you have steel that does not have the integrity in order to take the cut or to take the manufacturing, then it's obviously chances of that becoming deformed increases. So you really want to be careful with the way that you look at your needle design, and we'll talk about a couple of studies here in the next couple of slides. And it really relates to how do you select a quality needle. And so it's usually based on practice, individual provider, their perceptions and how things are working. And it can be different from one practice to another. It doesn't mean that one practice is wrong. You know, there's always this old saying that if you see one plumber's toolbox, you've seen one plumber's toolbox. The same can be said about dentists. I mean, each dentist uses things within their tool set that are particular to their practice. And a needle is one of those things. And the thing that I like to caution is I would really want to have more than one type of needle in my toolbox. And if I'm using just one, I may not be offering my patients the widest scope of what they need for their selection. So there's not currently a universal, there's not one needle endorsed by the ADA, there's not one needle endorsed by any organization or any dentist. So therefore, we kind of have to look at what we have available. Unfortunately, the needle market is not the most powerful, glamorous, or financially apt of all of the materials, equipment, and agents that we use. So research is fairly limited. There's not a whole lot of people that want to pay to see needle research. So we do know there's certain things that we want. We want it to be multi-beveled or scalpel beveled. We want a bevel design that's centralized with a long axis so it's non-deflecting. We like larger bored needles if we have comfort with the tactile ability to sense the change in pressure. Appropriate metal alloy, we want it to have the appropriate metal finishing, and at the end of the day it's got to be something that aids the practitioner in providing effective and safe anesthetic. It needs to cut with enough proficiency so that when you hold your syringe, you're not holding it very tight. It should be fairly loose, and it should not take the force of your hand, of your fingers, of your forearm, or your body to allow the needle to cut through the tissue. It should really cut like a warm knife through butter. It really should, and there should be a nice ease to the way that needle pierces and penetrates into the tissue. And if it's causing force or you feel it fold, the tissue fold down on the needle, that is not a good needle, not the type that you want to consistently inject into patients. So when we look at comparative studies, we don't have a lot, but we have a few. This is a study that was done by Sanchez. They looked at 7 different brands to identify the quality of the bevel zone, which obviously is the cutting area. And in this study, they found that there were 3 that were really good: the Carpio from Harries Kulzer, Teromo from the Teromo company, and Septaject needles from the Septodont company offered the best overall quality. When they looked at needles, they were finding a lot of this. And it's interesting because these are needles that were pulled directly from the box. These aren't needles that were used. They took these directly out of a brand new box, put them under electron microscope, and looked to see what it looked like. And a lot of the needles look like this. When we look at breakage force, which are things that we talked about, in this particular analysis, I always like to include it because it did say that all have different properties and that length and gauge do not directly affect performance during tensile testing. And so in this particular study, they didn't really find a difference between the 25 and 30 gauge as far as breakage goes. And so it's just an additional study to say here's what they found comparatively. You can see me hem-hauling around a 30 gauge needle because its use does have the majority of the market, and I do think it has some very good uses. Is it being overused in the profession? That is quite a possibility and something to think about. Bevel deformation, one of the things you should think about is if I'm looking at a larger bore needle, does that mean that the strength of the needle is going to be less because technically a larger bore needle with the same gauge means there's less steel on the periphery? And so Marquez did the study and found that there really was no difference in deformity between a standard Monoprotect standard, which is a Eurozone version of the Septoject and the Septoject XL needles, and didn't find that there was a difference in bevel deformation. And so given these conclusions, we know that there's differences that exist. You really need to understand what the manufacturer is producing, and we really need further research to compare the quality, efficacy, and safety of dental hypodermic needles. And a lot of this has to be done in a live patient venue, which is hard to recruit. A lot of people don't really want to be injected repeatedly for the name of study. So I'm getting a lot of questions, so I'm going to sum this up so I can make sure I can get to all those. The thing to think about needles, it seems like here in the dental profession we might not think about it as much as we need to. But just to give you an idea, History Channel's top 101 gadgets that changed the world, the hypodermic needle was named one of the top inventions. It was just behind the smartphone, radio, and television. And so this particular History Channel survey was done by thousands of viewers. And so it's something to think about. It is really one of those things that people have on their minds. Ultimately, if you have a quality dental hypodermic needle, you can improve the patient experience. And let's see if there's any good questions here.